All right. Good morning, everyone. Welcome to High Rounds for today. We have the pleasure of having Dr. Jill Blumenthal today, who's going to be presenting uh, presenting on community engaged research with transgender non-binary individuals living with or at risk for HIV in San Diego. But first, a few things about Dr. Blumenthal. She completed her medical degree from Cornell Medical College in New York and her residency in internal medicine at New York Presbyterian Hospital. She subsequently completed a fellowship in infectious diseases here at UCSD. And she is a board certified infectious disease physician who provides primary care services and specializes in caring for children, teens, and adults with HIV and AIDS. She has expertise in caring for transgender and non-binary individuals seeking hormone therapy and other supportive care. So, Jill, I'll peek at the chat pod and help out, but we'll figure it out.
Sounds great. Maybe I'll find it at some point. I swear I tried to bring it up. Well, good morning, everyone. I've been gone for a few months. I'll show you what I've been up to at the end. I tried to not make this super long so that there could be a good deal of engagement. And the one other thing that's not related to community engaged research is an update on our gender health program at UCSD that I'll talk about a little bit at the end. And Dan, thanks for that introduction. The other thing that I'll just like to say is I use my pronouns when I introduce myself. So I say I'm Jill Blumenthal, you she, her pronouns. And why does that matter? So why do pronouns matter? And if you saw, there was a link in the she, her, hers. I tried to make that work. Someone will have to show me how to actually do that one day. But this is a page it will take you to, and others have things similar to this. So why do pronouns matter? Using your pronouns can create a normalized space for people to share their pronouns who maybe wouldn't have normally done it or have different pronouns than, sort of what might be the standard pronouns. I think another thing about sharing it or having it is that it signals to others that you, maybe the group you represent or your organization, are inclusive and at least have a basic understanding of gender identity and the ramifications. And then I think this is the part that I like people to try to think about. There's privilege of appearing in a way that fits your gender and the pronouns that people associate with that gender. So when we share our pronouns, that can disrupt that normalization and the privilege of just assuming. I also had to share this today. Thank you to Dr. Darcy Wooten. We share these a lot. I don't know if others know Thoughts of Dog on Twitter, but really can bring a smile to the face. So I just wanted to read this one, particularly on a Friday. The human starts every day with a cup of warm bean juice. They say it makes them fast. I tried to sneak a taste, but was quickly denied. This is far from fair. I want to be fast too. I still haven't given my dog the bean juice, but maybe I'll have to try it this weekend and see. Here are my disclosures. So what we're going to talk about, I'm going to talk a little bit about the importance of community engaged research, just some thoughts that I have with transgender and non-binary individuals. I hope we can come back to that at the end. I guess I'd open it when the slide comes, but maybe we'll just save it for the end, Dave. Sorry. I'm going to talk about some local studies that I've been fortunate to be a part of that have dealt with HIV care and prevention in transgender individuals, provider awareness of gender affirming hormone therapy, and then some studies on PrEP and hormone therapy interactions. Some of my thoughts on best practices for collaborations with transgender and non-binary individuals, and then some updates for the gender health program. So this is a sort of a general comment, but I want us to think about it in the context of transgender and non-binary individuals. But I think you could use this question for really all populations that are historically underrepresented. So, what are some of those key considerations? I think, the first one, and it can be, we know how this sometimes go because we can pass right by it, but what does the community actually want? What do they want to know? What are they interested in? And where are the community members sitting? Are they part of the study team? Are they involved in the the actual study conception and then its design and implementation? Are the study goals that you have sustainable beyond the study end? I know that's a really hard one, and we talk a lot about what happens when grant funding ends and what that means. And has that really been thought of as opposed to just like future directions that we put in our research grants? Has the research team been trained in cultural sensitivity and humility? Do we know that they're going to come in and get an experience that feels appropriate for them? They're not, and it feels like they're included in something and not an outsider in the research they're participating in. And I'm just going to drop this here because I know it came up on the T32 call yesterday. I think this has been a hot topic, is what about payment? What do we do about payment? How much do we give? How do we give it to people? And what does it all mean? So maybe we can dialogue about this later. So this study was just published in 2022, but I know it's been presented by Sheldon Morris. It was led by him and David Moore. It was called the Randomized Trial of Individualized Texting for Adherence Building, ITAB, plus Motivational Interviewing for PrEP Adherence in Transgender Individuals, the IM-PrEP study. It was a 3.5-year study. 255 transgender and non-binary individuals were enrolled between San Diego and Los Angeles, where they got oral TDF, FTC for 48 weeks. And then they were randomized 1-to-1 to either receive just ITAB alone or ITAB plus motivational interviewing through phone calls for non-adherence. And the endpoints, which has sort of become standard endpoints for some of these studies related to adherence, are 2 different sets of concentrations, which represent very good, perfect adherence, and that's greater than 1246 femtomoles per punch and greater than 719, which is a protective level of protection, protective level of PrEP. I hope you can see the slides. Basically, sorry, I'm just trying to move my mouse a little bit. There we go. So the adherence outcomes, you can see in the columns there was no difference by any group or the entire cohort with ITAB versus ITAB plus MI. But what I want to show you is where there was a little bit of a signal. So for protective adherence, transgender women who received the motivational interviewing in addition to the ITAB, not statistically significant, but there was starting to be a difference for the adherence outcome in those who received the ITAB in addition, or the MI in addition to the ITAB. And then the other thing that came out, again for transgender women, but this was actually all people. So people who said, yes, I'm taking the medication, they also had higher levels of adherence or were more likely to have protective adherence in this MI group. So, what does that exactly mean? And I think there was some grappling with this, but, maybe there's something about this phone-based MI, and it basically came up when people repeatedly missed doses. It could improve PrEP adherence among transgender women. Is it having, knowing that someone is reaching out to you? Is it just the phone call? I don't want to deal with the phone call. That hasn't been explored, but something did come out here to some degree. And then we also looked at factors associated with adherence, and found that non-Hispanic Black individuals and those who reported exchange sex in the past year were less likely to achieve adequate adherence. I think the Black race has come out quite a bit, and I think we know it's very complex, and undoubtedly points to, systemic racism, which is a very hard concept to tackle in one research study. But so some of these findings we use later, and I'll show you how we harnessed these to think about some other studies. So Eric Storholm, within this study, the IMPREP study, Eric Storholm, now at SDSU, did some interviews with Black and Latinx transgender women in the study, and looked at facilitators of PrEP persistence in the study. There were 30 interviews conducted, but they only included, or in the study, it was only included people who had at least one protective drug level. So that ended up being 23 individuals. You can see the mean age was about 30, and 13 identified as Latinx, 6 as Black or African American, and then the majority identified as transgender women, trans female, or trans feminine. And then, so this was an interesting, this was something I hadn't seen before, and we thought about it a lot. And this was the idea, because the study had 2 time points at weeks 12 and 48, or the last study visit, we basically characterized persistence as either being high, low, or high-low. So high levels were people who both at weeks 12 and 24 met those protective drug levels. The low-high started low, but then ended up being high at the end. And then high-low started out with a protective level, but then later had a lower level. And so that was how individuals were grouped. And basically, the socio-ecological framework was used. So factors were looked at: individual, interpersonal, and community level, and structural levels. And the individual level facilitators, and again, I'm not sure how much many of these things would surprise people. So I think the ones that maybe stand out is the feeling empowered to take PrEP, that was a facilitator, and having improved peace of mind and mental health because of taking PrEP. The other, the interpersonal and community level facilitators, this is an interesting one that I think we like to, or we hope to see more, is feeling motivated to prevent HIV in the community. Sort of that feeling like you are part of something and want to be part of the solution. And then a motivation in the context of sex work specifically, and high HIV risk perception, which was also an individual level facilitator as well. So that's more having like group level high risk HIV perception. And then the structural level facilitators, this is something that we're really trying to harness and think about more, is having positive experiences in affirming healthcare settings, and as well as having PrEP visits combined with other gender-related healthcare visits. There was another paper that came out, just for the interest of time. I just wanted to focus on this one. But so basically, interventions may need to use multiple levels of support that come from different places, but that they're able to, because people can start and persist on PrEP, even though we know there's a myriad of social and structural barriers that people face. This was a study. This was one of the EHE supplements that was sort of ongoing while the IMPREP study was happening. And a lot of the people that were part of the IMPREP study helped inform this study. And this really was a collaborative effort. It was led by Laramie Smith and myself, but we partnered with family health centers, the T-Spot and Proyecto Latina. And basically, we were trying to plan a mobilized community-delivered response with transgender individuals at high risk for HIV transmission. It was meant to be agnostic of status, status neutral approach as much as possible. But we wanted to validate the acceptability and feasibility of 3 evidence-based practices that would reach and impact and underrepresented populations, which included peer navigation, mobilized medicine, and then the use of social networks to reach other individuals. And the other part of it was to identify areas in San Diego that could have the highest potential to expand the impact of non-clinic based HIV services. So where could we go to people where they're not being reached? And then the activities included conducting focus groups. There were key informant interviews. We did some hot zone mapping. And then we developed the program with all this information. And then we went back to the people who did our focus groups and did member checking, sort of a, did we get it right? Is this what you wanted? Or is this what you said to us, and how did we do? So for the focus groups, we conducted 5 of them. 2 were in Spanish. There were 30 transgender community members, about 60% were Latinx, 17% Black individuals. And we were really focusing on the hardly reached individuals. That was the focus of this. So 72% had reported engaging in sex work, almost 90% experienced violence, over 20% reported problematic substance use, and then over 50% engaged in all of those things, or were experiencing all of those different conditions or challenges. So these were, some of the questions that we asked in the focus groups. What influences how HIV services are perceived? And what came out was that stigma and medical mistrust are already deeply embedded. And so things are met already with the feeling of not trusting a system, and then also feeling like there's always been stigma and transphobia. And so that's sort of the play, that's where things start. And then what influences how the services are delivered and received. There has to be a perception of safety and cultural competency of the providers that are offering it. So if people go places where it doesn't feel like providers know what they're doing, or make offhanded comments that are transphobic, that they're not going to want to return there. What external factors influence how services are accessed? And again, I return to transphobia. This is sort of the bigger than the study often, but just the inability to access jobs, housing, having to turn to sex work, using substance use, unmet mental health service needs, and then in particular, people who only speak Spanish, having to speak to a provider through a Marty, as opposed to having someone who speaks the language that you do. And then the costs of accessing services, obviously the time, maybe the loss of income, the transportation. And I really want to focus on the emotional labor. And maybe we can come back to this later. I just want to put a pin in your ear. And I've had patients say, coming to see me, while it's great, it's also really difficult for them because of everything that comes up for them when they're coming into a visit. For some people, that's not the case, but for a lot of people that can be. And so, maybe that's just not something they want to deal with in that moment. And then how could infrastructure needs enhance HIV services? Well, getting services from providers who look and talk like you, having more trans people there, and particularly having more bilingual trans providers as well. And I just wanted to make, I sort of hinted at this, but when a negative experience happens for someone at a healthcare facility, not only is it re-traumatizing to them, but it can really affect the reputation of that agency. And it's a small community. People say, don't go there, and someone might not be seen again. And then I brought up the Spanish speaking having really fluent providers for Latinx participants. Basically, in an effort to develop the program, we wanted to focus on the things that came out. So how do we reduce stigma and medical mistrust? Peer navigation was going to be this active ingredient to help reduce those factors. When there were structural barriers and access issues, that using both mobile platforms and actually mobilized medication going to where people are was seen as being beneficial. And then, how do we get to safe and competent or sensitive care? Greater transparency and accountability for how lapses occur and how they're being responded to, with the plan to eventually form a collaborative working group that would focus on accountability. So this was our grand plan, and we applied for further funding, which we didn't get because this was just the planning phase. I don't know if Laramie's on right now. We really do want to put this into action. When we presented this back to when we did the member checking, the response was, this is so great, and we really want to see this. You really heard what we said. This is definitely not a cheap grant because mobilized medicine is very expensive. And that was really where we had a lot of problems. And every time I talk about it, I'm sure I will send an email to Laramie later if she's not on here and say, let's talk about this again, because we really liked it. But it was, and this is also what ends up happening, right? We form this great collaboration, and then what do you do after? Fortunately, and I will say much thanks to Laramie, we've continued to work with these organizations to do other grants together. And I think that's what's really important. Even if you don't get the next grant related to this, you keep moving. Yes, and I see Anik's hand. Dan, should I stop for a second? Because I see there's also stuff in the chat. I can finally see the chat.
Yeah.
Okay.
Anik?
Thank you, Dan, and thank you, Jill. This has been so great to hear about transcending. But my question was in regard to transcending. My understanding is that there's now an Arrow one that's following up on that pilot, right?
No, so there's Transgender Ending, which is a CHIRP grant, and it's a different structure. And I'm not talking about it because it's in its early phases. So the collaborative is the big part of this. And I think a lot of, and I don't want to talk for Laramie because it really was her baby. But I think a lot of what came out of this collaborative working group came from what we learned from this study. But it's not an R1, it's a CHIRP funded grant, but I think there will be more with this. But it doesn't have the first, well, the idea is we're going to use the collaborative to create a program that we want. So, okay, yes, maybe it's a continuation of this, but
let's call it that. Yeah.
Yes, we'll say that. So anyway, thanks for bringing that up. Okay, and I see there were some other questions. The Southern California. Yes, Darcy.
Yeah.
Okay. So I'm actually, and thanks for that plug. That means Laramie will have to come and talk about the study because it is a really exciting and interesting one. All right, I'm going to shift gears a little bit and talk a little bit about some more of the biomedical aspects and the provider part of this. There's been an interest on, what happens on the provider side. Clearly, it comes out a lot that patients say, I want to be seen by a provider who knows what they're talking about, and I don't have to teach them. So in conjunction with the IAS USA, Sophie Cannon, who's now an attending at UCLA in endocrinology, when she was a resident, we worked on this study together where we assessed knowledge of, experience with, and willingness to prescribe hormone therapy to transgender individuals with HIV. And it was a national survey of HIV practitioners, online survey sent. Just shy of 400 people responded. They were mainly primary care doctors and ID HIV trained practitioners. So what was good was that more than half prescribed hormone therapy, but that's obviously still not close to the level that maybe we'd want it at. And only 7% had received formal training. And obviously without any kind of formal training, it means that providers could be doing sort of whatever they want. It may be fine, it may be harmful to patients. And so it clearly showed, and I didn't present it here, but it also, we found that there were very high levels of interest in getting formal training. Some of the main barriers to prescription, lack of training was one of them. And then a lack of transgender individuals living with HIV in their own practice, having qualified mental health professionals to potentially support patients, and then believing that it was outside of the scope of practice with a smattering of other issues that people identified. And we actually then took this and did a similar study with primary care physicians in Southern California, looking at similar things. And I will present that in the future. That was done with another great resident who's going into endocrinology, Allison Yip. And we're working on that manuscript now. So, but the punchline is there needs to be more training for providers, definitely with those who have interest, but even bare bones, people need to understand this, and competency is extraordinarily important. Okay, so now I'm jumping back a little bit. This is a study, or this is poster that was presented from a study that we're doing. It's co-led by myself and Heather Pines, where we're looking at, we basically wanted to develop an intervention that would help support transgender women or trans feminine individuals assigned male at birth re-engage with PrEP. So people who were experienced with PrEP but for some reason had fallen out of care. And we used the findings from the I Am PrEP study to help us start with some interviews. And so basically what Jackie Andreescu, one of the postdoc students, presented was a mixed methods sequential explanatory study. We had two phases. The first phase, we looked at quantitative data from the I Am PrEP study of the transgender women. We looked at 24-week retention by sociodemographics, engagement in sex work, substance use, and hormone therapy use. And then based on what we found, we conducted 15 interviews with PrEP experienced transgender women. And because of that finding that I'd mentioned about sex work before, we purposely oversampled to include transgender women who engaged in sex work. Basically, you can see the socio demographics here. What should I point out? 20% Black individuals, 40% Latinx. 2/3 were currently on PrEP, and 60% were sex work experienced. And so from phase one, what we learned was that transgender women not retained at 24 weeks were more likely to have reported sex work. So then we wanted to explore sex work a little bit more, and basically found two subcategories of sex work engagement. There was the non-survival sex work. These are people who were very stable overall. They had stable housing, they were using providers, they were exchanging sex for money, they had online clients. And then there was survival sex work. And those were people who had a much more difficult time staying engaged in PrEP. They had more street-based clients, housing was less stable, etc. So that was something that came out of that part. We also saw that transgender women not retained at 24 weeks were less likely to report hormone therapy use than those who were retained. And what we found in the interviews is that people continuously and consistently prioritized hormone therapy over PrEP, noting that hormone therapy was a life-saving basic necessity like the other things, housing, food, hormones, but that there were a lot of benefits of being able to access hormone therapy and PrEP together. Which again was we found in Eric Storholm's previous study. And then transgender women not retained at 24 weeks were more often reported severe drug use. And then just basically what came out of the interviews was that drug use, probably not surprisingly, was a barrier to PrEP, and often in the context of sex work and the people who are engaged in survival sex work. Those who engage in survival sex work have significant barriers to PrEP retention and probably need a lot more resources to help staying engaged. And then, these reciprocal benefits of hormone therapy and PrEP really highlight the need to co-locate these services together, and at least have them available to people in both places, which means that our endocrinologists need to start learning how to prescribe PrEP, something that we're starting to talk about a little bit. Sorry, I got stuck here. I believe I already presented this, so I think I'm going to hop through it just in the interest of time. I believe I did. I'll just quickly summarize bidirectional effects of hormone therapy and TDF FTC PrEP. This was one of the largest studies done. This was part of the IM PrEP study. And there have been other studies, but this is really the largest, looking at individuals and any effect of PrEP on hormones and vice versa. And we looked at it by sex assigned at birth, and those taking stable estrogen and those taking stable testosterone. And there were no changes in their estrogen concentrations and no changes in testosterone concentrations in those who had started taking PrEP. We did ponder a lot in the testosterone level. You can see there is about 100 nanogram per deciliter difference. And for some people, that actually could be a lot, depending on who you are. Obviously, the p-value is not quite significant. We talked about this a lot. The good news is we know testosterone and estradiol concentrations can vary quite a bit. This still doesn't make me change anything with my practice, but it was something that we did find that perhaps there was some decrement in the testosterone concentration, but undoubtedly not likely to affect someone's experience, which is what we also looked at here. I'm just going to point out, we asked people about body image satisfaction and satisfaction with their hormone therapy on gender transition, and individuals at week 0 compared to week 24, they experienced no differences once they had started PrEP. Basically, did the PrEP affect you in any way? And there were no changes in that sort of perception, which in a lot of ways is the most important things. Hormone levels matter, but they don't matter that much. I mean, they can, but this is, but the experience is what's most important. I'm going to skip talking about the genital microbiome and tenofovir levels, because there could be a lot here, and I don't think we have enough time. Another study looking at hormonal measures in transgender, this was actually in transgender women, so transgender individuals assigned male at birth, switching from TDF FTC to TAF FTC. So this is the drug that a lot of people now are on. Do we know if there are any interactions between those medications? We had 30 participants. And this, we did include transgender men and individuals assigned female at birth. This particular presentation focused specifically on individuals assigned male at birth. And the great news is that there are no changes once you switch from TDF FTC to TAF FTC in terms of hormone concentrations, and regardless of whether you're using estrogen. Oh, I guess we didn't. Oh, no, sorry. These are the testosterone levels. Sorry, now I'm getting myself confused. No, this was just assigned male at birth. So the estradiol levels don't change and the testosterone levels don't change, which should be lower in individuals who are taking hormone therapy. Sorry about that. But bottom line, we had a lot of data on TDF FTC, and I believe this is one of the first studies looking at TAF FTC, and that was led by Nimish Patel. Finally, I'm so sorry. I'm totally going to skip this because this is much more complicated, but I will come back and do some more of this, the more basic aspects of this that we've been doing. And I think I just wanted to make the point with community engaged research that when you do studies where sometimes we want to get a little bit a little bit more nitty gritty with some of the pharmacology and some of the other aspects that maybe are of interest to scientists and actually affect what we tell patients, it is necessary to include community members in this, explain why this is so important, and to talk about it in a way that makes sense to them. So we were able to leverage the studies that we've done and enroll close to 25 individuals with trans experience for rectal biopsies, which is not an easy task to do. Lalo Kachai did the biopsies. It was incredible. I'll come and talk about that later because that's a whole study in itself that could be a presentation. So these are some of the things that I thought about in terms of best practices for successful collaborations with transgender and non-binary individuals. And again, hopefully we can come back to this, you starting with community advisory boards, you can help establish them, but they need to be co-run by people in the community and eventually run by people in the community. And the community advisory boards actually need to direct some of the work that you're doing. You need to pay transgender individuals for all their work, including outreach and recruitment. I think there's been a lot of, over time, we've asked people, hey, can you tell the clients that you see for this, or can you hang up flyers in the rooms? Well, all of that can take time and effort for people. And it's really important that you acknowledge that work and pay for it. If you build a strong collaboration, that leads to future opportunities. You can keep working together on things that have worked. You need to communicate the results in understandable language to community members. So the slide that I decided not to talk about just before, that's going to be one that will be really hard, I think, to translate to community members, but that's going to be something we make sure that we take the time to do when it's all said and done. It's important to train the staff on the appropriate use of language so that you can have positive interactions. You need to be present. I think, especially if you're leading studies, you need to be present and be visible so that people start to trust you, and obviously it should be genuine. And then advocate for changes outside of the research domain, just in things that you're seeing, and see where you can show up. So I am very proud of our CFAR Transgender Non-Binary Community Advisory Board. This is sort of a picture of some of us. It was a little bit of a mix from Pride last year, and our goal was to established to improve and sustain health and well-being of the transgender and non-binary community. And we really wanted to build bridges that helped foster health research, but it also included holding community events that weren't related to research necessarily, and increasing community education and advocacy. One of the big products that we developed, led by Jordan Silva, was a best practices report for identifying and including transgender and non-binary participants in research, helps give information on how to ask best questions for SOGI collection. And I think that is available on the CFAR website. And it's a really great document. I also just wanted to bring up something that I got to be part of, which was really interesting, and it was now accepted and published in CID, but led by Sarah Barres from the University of Nebraska. Basically a call to action, prioritizing the use of inclusive and non-stigmatizing language in scientific communications. We all know this. I think this is a group we've said this time and time again. So I think this is a group that's way ahead of the curve for this, but that we know that the language that we use in scientific communication can really empower people, but it has the ability to stigmatize. And CID was basically saying we're committed to doing this, and asking other not only submitting authors, but reviewers and editors to do the same. They were saying we can't do or fix everything, although I would say maybe you can, but people who are submitting should be thinking about these things. And there was a nice table on some terminology to avoid and suggested alternatives. We also, myself, Dan, Lee, Elliot Welford, and Marvin Hanashiro developed something that is meant to be given to all our higher presenters. I don't know if we've been trying to publish it. It's been rejected now 3 times. So it's just a 2-page guide on sort of what to think about when you're giving presentations, how to be inclusive, what to think about with the images that you display and all of that. And maybe we will actually circulate it more going forward. I got a lot in my mind right now, I'm sorry. But anyway, this was, take a look at it if you're interested. And then I wanted to make sure I talked a little bit about our gender health program at UCSD, but maybe I should stop for one moment to talk about the research. I'm just keeping an eye on the time. I've got 5 minutes, right?
8:40.
I'm trying to wrap things up, but we'll see. Yeah. I see Nettie's comment. I don't know if Nettie, you would like to share what you said.
Which thing did I say?
Did you say
about
anything?
the
mobile part.
Oh, okay. Yeah, I made a
Yeah.
comment about always using your research money to buy something that actually lasts, which
Yeah.
I think is important, as opposed to, we also want to pay people, but you know, if your project can also provide COVID testing for the whole community while you're also COVID testing for your study population, or you know,
Yep.
fund a van that stays with the community health center or whatever, that kind of thing we should be doing with our research. What I was going to say is that, speaking of mobile services, just for this group's conversations around how do we keep our work sustainable, you know, from the clinic direction perspective and keeping your clinic sustainable, it's actually really, really hard to, you know, everyone says, let's just go out in the community and do mobile health services. And it's huge for our population. We really need to be able to provide services where the people are living, be it on the street or in their homes, whatever. But actually, just like throwing a provider on a mobile unit is completely unsustainable from the current business practice of clinics. And so I think sharing within this community creative ways that people have found to do that. We're kind of trying to straddle a line of like which services are sustainable to provide in the outreach setting, and then link back to the clinic setting for things that can't be done remotely, and where is that like tipping point of where it becomes sustainable or not. With telehealth, I think you can do telehealth visits from your mobile unit, which would maybe make your program more sustainable. So anyway, I was just opening that community conversation about the realities of being able to operate in the US healthcare system, while also recognizing that we got to be able to do it from a van sometimes.
Anik, did you have a question?
Yeah, but it can wait to see if we have time at the end.
Thanks,
Thank you,
Anik.
Dan.
Okay.
And I just popped and yeah, I saw what Edie wrote. I
You
try
wanna
to let
address
people
that?
self-identify, Edie, and if someone describes themselves as a lesbian, or if they just say, you know, I have sex with women, I try to, I guess I try to use the label a little bit less when I can, but obviously our health system and sort of the categories, I think you were referring to SOGI, and SOGI still lists it as lesbian. So that is still the language that's used there in best practices for SOGI collection. And then I just popped in Las Patronas, UCSD, we're not eligible because I think once UCSD, like once your organization gets a grant, you can't get it for another 3 years, but they fund only, I lost the word I wanted to use. But just, you know, goods. They don't fund personnel. So it's a great place to potentially say we need a van. So just food for thought for other organizations.
Anik?
Capital expenses.
Yes, it's just that my comment is actually related to the whole lesbian term, and
maybe we can come back to that at the
for...
end, if that's okay, Amy.
Okay.
Is that okay? Okay.
Yeah, that's fine.
Thanks. Okay. So just our mission for gender health, we want to provide affirming, inclusive, and comprehensive care to transgender and gender diverse communities. And we're using the triple A's, accessibility, advocacy, and accountability, to improve the overall well-being of patients. This is, so what I'm showing on the left are all the services we offer. We straddle 10 divisions and departments, which is a lot, and why the coordination of this has been really challenging. And I know we'll keep talking about the program. We have a presentation at the Owen Clinic coming up. What you see on the left-hand side are people who have somewhat self-identified, but also been a little bit vetted by us as people who are part of the gender health program more specifically, and have some of this additional expertise. It's not perfect. There are people missing who we know should be on there. But we also wanted to create a list that was somewhat comprehensive. And you can find this on our website, which just underwent a redesign, so it looks even better. And I wanted to talk about just briefly about our program services. The picture you see in the top right-hand corner is our wonderful program coordinator, Rai Camiso. He's the they, them pronouns. I think a lot of you have met them. They, along with our program, focus on patient support. They do a lot of intakes and follow-ups. A big component are letters of readiness for surgery. And then it's working with these 10 specialty departments. Authorizations are a big issue, and we hired a gender health authorization specialist, which we're still trying to iron out. And then we're also a big focus of program development. We finally have a gender health epic order in. It always needs tweaks. Policies and procedures across programs. How does this work? And then making sure that staff are trained on all of these referrals and they know what to do with them. One of the bigger areas that we're starting to do is training and education. We want everyone to have the basic knowledge of gender health, but then divisions and departments that do this a lot really need to know more and need to be doing this to the top of their level, their game. And then we're also tasked with leading, transgender, non-binary, and sometimes we also get LGBTQ plus efforts are combined with this, which is true, but not entirely. Those systems or that system wide. And then we're really working with the community as much as we can. An internship was created for people. I forgot how proud I am of this next slide, and I realized that, again, we're running out of time. These are all the things that we've been working on, and these are things that I've been very heavily involved in the last bunch of years with various people. A lot of it I just talked about: patient support, the program development. I think some of the other things to highlight is a lot of the training and education that we've done. We developed a CME accredited gender health grand rounds that's once a month on Mondays. I think most of you, or a lot of people, are invited. We talk about patient cases that have been difficult for us to sort of know what to do, and we talk with our colleagues and we present research. And then this year we held our 4th Transgender Healthcare Symposium in December. We'll be doing our 5th one this year. We have a lot of community partnerships. One that I'm particularly proud of is Legal Aid is now coming to the Owen Clinic to help support people where they're having insurance issues. They're not just doing it for trans and non-binary individuals. It's happening for anyone who's having issues with PrEP or PEP or their HIV medications. Epic has been a big bundle of fun to work with, but we've made a lot of changes. I see Nettie. I think we can share what we have once we're done, and we've done a lot of that, and I think that can be helpful because we have a lot of screenshots, so we can happily share them. It does sound like it's easier to move Epic to Epic now because Rady just asked for something related to a smart set that we have, and I think you can do that more easily. And then another big thing is sort of having more support on the medicine side. And we now have a wonderful new endocrinologist, Ravi Iyengar, who's going to be able to be seeing a lot of patients for hormone therapy, who basically developed a program very similarly at Rush University in Chicago. And he's here with us now, and he's going to be wonderful for everyone to meet. All right. I think that's everything I have. I just wanted to thank a lot of different people who really made a lot of this work possible. And the funding is over there. And in addition, just I wanted to highlight some of the other people in the gender health program. Jennifer Anger and Amanda Gossman have really made this possible. It's been a lot of work, but we're finally getting there. And we newly hired another plastic surgeon who's going to be doing a lot of the gender affirming surgeries. Her name is Priya Lewis. She's great. She starts in July. It'll open up more access for surgeries at UCSD.
Great. Well, thank you for that. I guess we'll have Anik again.
Yeah, it was a very brief comment about the fact that, as far as I'm aware, lesbian, homosexual are not wrong or offensive terms. It's just wrong to assume that somebody who has sex with, that a man who has sex with a man identifies as gay or homosexual. But I actually think that people who are gay or homosexual would prefer being called gay than a man who has sex with a man. So I would, that last line in that table, I would have I don't think it's correct, because it's not a wrong term to say homosexual or lesbian.
So I will just push back a little bit. I've definitely been on calls where, and I'm not a gay man, so I should say that. But that where people have really pushed back and said, I don't like hearing the term homosexual. And that's a term that's, I think, just less used in scientific communication. I think a lot of people will identify that way, but I think in scientific communication, again, this is where I think there's a lot of nuance to this. It's how we maybe write about it, but then we're actually talking with people that might not be, I'm not going to be like, so are you a man who has sex with men? And that's not how I'm asking the question, but it may be the way that we're communicating it scientifically. I'm happy for others to comment on that.
Jill, I didn't know, yeah, I mean, I know you're reading through the chat. So I see Kimberly said would love to be included in Monday case reviews. Do you know how, like?
Yep,
Yeah, okay.
I'm in charge of it right now. I have I think there are about 110 people on our listserv. It's really fun and well attended. We actually have a case on Monday. One of our plastic surgeons going to be talking about some of the challenges with breast augmentation. So some of it's very clinical for all of our PhDs on here, but some of it is not. And you can always see it's on me. I usually send out what we're talking about a few days before. It's not as well organized as this or some of our other rounds, but yeah.
Before we show baby pictures, I see that Daphne had mentioned, I don't know if you saw her message, mentioned earlier that PrEP to hormone care, linking PrEP to hormone care, co-locating as an avenue to increase uptake and retention. Other considerations linking PrEP with substance use treatment, mobile syringe exchange, on the ground harm reduction outreach. Not sure if this is already being done at UCSD or not. Do you know about that, Jill? Or
I mean, this is what we do at the Owen Clinic, right? This is our bread and butter. This is what we're doing. I think minus the and others can comment, the mobile syringe exchange that isn't exactly attached to us, but is affiliated with us with Prevention Point. I don't know if I'm saying the right word. Anyone can jump in. We are doing this. This is the work that we're doing. And I think, like Robert said, this is what we're discussing constantly. In a lot of our proposals, we are definitely doing this work. I think what is very tricky is the funding is very difficult in historically in places that are Ryan White funded, because what other sources of support do you have to fund the things that aren't related to HIV care? But it is something that I think most of our clinics are starting to do better and or well.
okay.
Maybe not well. I'll just say better. Is it baby picture time?
We have a demand for baby pictures.
Well, I just wanted to take people on a little cruise of what's been happening in my life for the last few months. So I just wanted to brag about Tallulah. Can you see my pointer?
Yes.
Okay, so this is my little Tallulah with her pack that she gets to play with. It's really great. Dog tired. She runs around, gets really tired on Fiesta Island. This is actually from my wedding a few years ago, but I wanted to highlight my amazing grandmother, the matriarch of our family, who just turned 94 years old. And I think we can all aspire to live like that. And these are some of the amazing women in my family. This is what happened to us in the beginning of January. That's Billy and my parents, my stepdaughter, and my wonderful husband, who has been really an amazing dad to Billy, this little munchkin who now smiles and is really hard to leave. But this is what's been going on. So here's the baby pictures, and this is what life looks like now. So happy to, I hope to bring her around a little bit more. Some people have seen her on Zoom. I'm trying to get her used to, like, this is what life looks like. We have to talk, we have to do things. There's a hustle and bustle sometimes. But anyway, thank you for the thank you. Thank you for the comments. And yeah, I think, oh, we're at 9.
We are at time. Yep. So thanks, Jill, for a wonderful presentation. Jen, thanks for all the work you are doing for our entire community. It's